My role today is to cover the role of endoscopy in neuroendocrine tumors and in terms of diagnosis and treatment. And I'm going to cover mainly diagnostic pictures and techniques and look at endotherapy, and also mention a little bit about endoscopic ultrasound. You've heard already about the different grades of neuroendocrine tumors, and our management, even at an endoscopic level, will be dependent on the grading of neuroendocrine tumor. In essence, I'm just a plumber, and it's quite easy actually. The tube's fairly straight and long, and you can go from either the top end or you can go by the bottom end. My wife would say that I would certainly argue with the thought of me being a plumber, but because I'm totally useless at home when it comes to anything, fixing anything to do with that. But certainly with an endoscope, I can find my way around. Either the bottom end or the top end seem to be okay. Now, what you'll notice, in fact, in terms of this cartoon, is how long the small intestine is in terms of 5 or 6 meters long, and how difficult, therefore, it can be to image and be able to treat lesions in this tube, and I'll address some of that as well. Let's start at the top end with the esophageal neuroendocrine tumors. These are rare, in fact, and often quite aggressive tumors with a poorer prognosis, often needing radiotherapy or chemotherapy as part of their management, unusually. But patients may present with difficulty in swallowing and having strictures, and you can see at the top a picture of the narrowing there. And so this patient may present with difficulty swallowing, maybe vomiting. You can see below that, actually, what we can do, we can dilate up strictures with balloons, and then you can see a radiograph of balloon being inflated inside the esophagus to stretch it and open up the stricture. And then in the bottom panel, where you can see again stricturing, we can actually put it's like scaffolding. So it's a wall stent which we can place down via the endoscope into and across the stricture to open up to enable swallowing. So in addition to taking biopsies for diagnosis, there are interventions that one can perform, and also for a small number of patients, occasionally we can do even radiofrequency ablation to burn away tumor within the esophagus. Moving on to the stomach, there are 4 types of neuroendocrine tumors in the stomach, types 1 to 4, and these polyps account for 2% of all gastric polyps. By far the most common is the type 1 gastric neuroendocrine or carcinoid tumor. It's the most indolent, associated with usually autoantibodies that attack the acid-producing cells in the stomach, so you don't produce acid. As a result, high gastrin levels, hormone levels, try and make the stomach produce acid. But those hormone levels, instead of being able to make the stomach produce acid, actually cause the endocrine cells in the stomach just to grow into neuroendocrine carcinoid tumor polyps. What's interesting, I thought, was that in this very recent August 2020 review published, that actually within the review, I think that there's statements in there which are completely wrong, and you shouldn't have it in there these days, such as aggressive gastrectomies. We just wouldn't be performing that. And so actually, I think it's I think for patients and doctors alike, when you see reviews, it doesn't mean to say that they're totally correct, and I think they're open for healthy debate. So the type 1 gastric polyps are the most common and most indolent. Often polyps can be removed endoscopically if needs be, if they're greater than 1 centimeter in size, and I'll come on to how that can happen through the endoscope a little bit later on. You've got type 2 associated with gastrinomas, Zonja-Ellison syndrome, extra acid in the stomach, high hormone levels, the hormone gastrin being produced by the tumor this time, and causing acid to be secreted, make ulcers, but also the hormone stimulates the endocrine cells to produce polyps called type 2 gastric carcinoid polyps. Type 3 are much more active, aggressive type of tumors, not associated with hormones as such, with normal acid levels as well, and as what's called sporadic, can act like localized cancers depending on the grade of their tumor, and often require a resection, a localized resection to remove the polyp. Type 4, very rare, can be associated, but not always, with higher levels of gastrin, usually associated with the acid cells not being so effective in the stomach, and are often large polypoid lesion, again, will require a surgical resection, just localized usually. I just want to tell you the story of a 52-year-old lady who came to see me 10 years ago for investigation. She was referred as a second opinion. She had investigation of anemia. She had multiple small polyps in her stomach, had low-grade carcinoid tumor. A local surgeon said, "You need a total gastrectomy." This was 10 years ago. So she came to me a couple of days before her operation. We sent off the confirmatory antibody test, so she had the gastric parietal cell antibodies, autoimmune phenomenon, high gastrin levels as predicted. Down the endoscope, we could take her gastric pH, which was as predicted at the alkaline level, and she had an atrophic gastritis, low-grade neuroendocrine tumor polyps, and in fact, her follow-up was not a total gastrectomy, but annual endoscopy. So it shows you that it's important. Now, each year I'll have 1 or 2 patients who are referred for total gastrectomies, and that would be inappropriate and a disservice to the patient in terms of their quality of life. It's important to understand the biology of the patient, and also for patients to be seen, therefore, in specialist centers. This is a picture of a patient with Zonja-Ellison syndrome. This patient had multiple neuroendocrine tumor polyps within the duodenum, gastrinomas associated with high acid levels, causing gastric ulcers, duodenal ulcers, but the thickening on the left side of the folds of the stomach and the polyps there as well. And this patient is just on a high dose of an anti-acid agent, omeprazole, and on a somatostatin analog. In the duodenum, moving along the intestine, most of the duodenal polyps are non-functioning and often small. It may be that you would just keep them under surveillance. You can remove them endoscopically. The wall of the duodenum is very thin, and so there is a risk of perforation, and you always have to take that into account. Different types of functional duodenal neuroendocrine tumors exist as well, those secreting gastrin, gastrinomas, and you would look to remove that if possible. Somatostatinomas are often found just where the bile drains into the small intestine, and in that similar region as well, you can get paragangliomas as well. So where a neuroendocrine tumor polyp is situated gives us information often about the biology of the tumor as well. This is a small duodenal polyp, and ordinarily you might often just keep that under review. This is an endoscopic ultrasound showing the invasion of this polyp. And in fact, this polyp had local lymph node involvement. So this patient did go to surgeon and had a gastrinoma which was causing problems, and the primary and the lymph node was resected. But again, there are all these different surveys and review articles, but often they don't include the question about surveillance, doing nothing but just for a low-grade tumor. And I have plenty of patients with duodenal polyps and gastric polyps where we just keep them under surveillance, and at 10 years or more, there's not been a problem. And if you're keeping a close eye on patients, then sometimes actually that is the better route, rather than being active. Just because you can do something doesn't mean to say you have to do it. Now, close to Israel's heart is Given Imaging, and they had discovered or founded the small bowel capsule to look at that 5 to 6 meters of small bowel that you can't see properly. Brilliant technology. You have electrodes that you wear, a little bit like an ECG. This is on the left in the hand is the lapel camera. You wear a wireless pickup to which the camera transmits, and that recorder, the wireless recorder, then can download onto a TV screen the pictures in the small intestine. There are now, in addition to the original given imaging pill camera, you've got Olympus and other companies making their own pill cameras. You get very good pictures of the small bowel, and you can detect neuroendocrine tumor polyps and other polyps and bleeding points within the small bowel, and so can be useful. But you're only limited to being able to see points of interest. You can't do anything about it. You can identify where something is. It helps inform, for example, the surgeons what to do. Or you can go with an even longer telescope called an enteroscope, which is a few meters long. And to get round the windy small intestine, it's got balloons on it, which can grab onto the intestine, and then you can manipulate the scope and by inflating, deflating balloon around the intestine, and hence it's called double balloon enteroscopy. So you can go via the mouth, or you can go via the bottom and up through the colon, through into the small intestine that way, or down, as I say, through the mouth, and identify lesions. So this is a colleague of mine, Ed Despot, who's an expert in doing this. This is the loopy small intestine going round and round. And here we can see a tumor in the small, far down the small intestine in the ileum, which was tattooed, so it makes it easier then for the surgeon to find it at operation. On the right-hand panel, you can see a little bleeding tumor, which was tattooed, but also, in fact, that was able to be treated endoscopically so that you could stop the bleeding at that time, which was an important therapeutic advance for that patient's management. Endoscopically from the mouth, you can also do endoscopic ultrasound, normal endoscope with a probe at the end of it, and this gives us pictures of the pancreas, which can lie behind, with polyps in the stomach, how deep the polyps are penetrating into the stomach, and similarly for the small intestine as well. On the left, you can see the pictures for the stomach, the pancreas, and really quite clear pictures, and the vessels. And during an endoscopic ultrasound, you can also take needle biopsies as well. This is a typical picture of a pancreatic neuroendocrine tumor in the neck of the pancreas. And this is helpful in terms of the surgeon for staging the tumors. And for insulinomas, which can be very difficult to diagnose, actually you can squirt in bubbles which light up the neuroendocrine tumors. An advance in endoscopic ultrasound, here you can see just a fine needle going into a pancreatic neuroendocrine tumor. This is an insulinoma in a patient not fit for surgery. And with this needle, you were able to perform radiofrequency ablation so that you could then burn away the tumor within the pancreas. And with the contrast enhanced endoscopy, you can see this organization of the lesion. This patient then didn't have any further hypoglycemic attacks due to the insulinoma. Moving down then to the rectal neuroendocrine tumors, what's very interesting for rectal neuroendocrine tumors is they're more common in Southeast Asian populations, and also in Black Afro-Caribbean origin as well. And I think looking at the ethnicity and looking at the epidemiology of all neuroendocrine tumors is important from that perspective. Most are found incidentally, though, when the patients are undergoing colonoscopy for other reasons. Most occur within the rectal neuroendocrine tumors just above the anal canal, within the middle of the rectum. And if it's less than a centimeter, actually, the chances of neuroendocrine tumor spreading is very, very small. If it's 1 to 2 centimeters, then actually a lifetime risk of perhaps 1 in 4, depending on the type of neuroendocrine tumor polyp. Certainly greater than 2 centimeters, you're thinking of surgery, because the lifetime risk of spread is much higher. And polyps can look different. So the polyps at the top of the picture, actually for small neuroendocrine tumor polyps, these ones very rarely will spread. Whereas at the bottom, where you see irregular mucosa, some central ulceration, puckering there, then these are the ones which, even though small, may show these are features that they could be more aggressive. And to remove polyps, you can now do endoscopic mucosal resection. So simply you inject some saline and adrenaline just to raise up the polyp. You can put a band at the base of the polyp and then snare underneath to remove the polyp. You can actually do something called endoscopic submucosal dissection, which is going even deeper if the polyp's invading a little bit more. The deeper you go, the greater the risk there is of perforation. So this has to be done in very expert hands, but you can remove polyps that way. Overall, the evidence is that there's probably, it takes longer to do endoscopic submucosal dissection. There's an increased risk of perforation the deeper you go. But there's ambivalence as to whether that is any better than the endoscopic mucosal resection. So there's where you're just taking away the first layer, if you like, of the stomach or rectum. Time will tell which is better. The last thing you want to be left with, however, is little bits of tumor polyp left behind. You need to make sure that it's completely removed. There can be a role for transanal microsurgery, so which can be done then via the surgeon through the bottom endoscopically as well to remove full thickness polyps. Again, there are guidelines as to management. Again, surveillance often not included, but they are helpful in giving what to do for different sizes and types of rectal polyps. So in conclusion, one can say that neuroendocrine tumor cases all polyps should be discussed in expert MDT. Often patients require staging, except for those probably less than 0.5 centimeters in diameter. Endoscopic ultrasound is very helpful. Occasionally, in terms of that staging, the Gallium PET scan is very important, particularly for polyps over 1 centimeter, and definitely for 2 centimeters in size. Surveillance itself on its own may be appropriate for sub 1 centimeter polyps in the stomach and duodenum if you know what the biology is of them being low grade. We can remove polyps endoscopically, mucosal resection, submucosal dissection, and that depends on size or any adverse features. You can do minimally invasive surgery, depending on the size and grade. But the follow-up is really tailored to each patient on the size, presence of adverse features endoscopically, and also what the patient wants and the comorbid issues the patient may have. With that, thank you very much.